Assalamu alaikum. Hi, everyone. It's honor and pleasure to be with you. I'd like to thank the organizer for giving me the opportunity to talk to you today about TSH receptor antibodies assay. I have nothing to disclose in relation to this lecture. When we talk about TSH receptor antibodies, we talk about something that play a very key role in autoimmune thyroid disease. It's primarily associated with the Graves' disease, but it's also seen on the thyroid-associated arthropathy and Hashimoto's thyroiditis. So understanding the pathophysiological role, the clinical impact, and laboratory assessment is crucial for the diagnosis and management. The TSH receptor, what we know as a thyrotropin receptor, is a G protein, which is coupled receptor found on the follicular cells or thyroid follicular cells. It's activated by the TSH, and that will lead to the synthesis of thyroid hormone and the release of the thyroid hormone. The TSH receptor antibodies actually mimicking the TSH action. So TSH receptor antibodies can either stimulate, block, or neutralize the receptors, and that will give us a different clinical outcome. What are the types of TSH receptor antibodies? There are three types. One of them, we call them thyroid stimulating antibodies. So what's happened on these thyroid stimulating antibodies, it will bind to the receptor and will stimulate the receptor. So it will mimic the action of TSH. And in that case, we'll get the Graves' disease or hyperthyroidism. Or this receptor will become blocking the receptor. So the TSH receptor antibodies will block the binding of the TSH, and it will reduce the hormone synthesis. And in this case, we get the hypothyroidism. Sometimes the antibodies are neutralizing in nature, so they compete with the TSH for the binding to the TSH receptors, but they do not have any significant stimulatory or inhibitory effect, and we are not clear about what is the pathological role of these TSH receptor antibodies. What are the advantages of measuring TSH receptor antibodies? One of it is its use in the differential diagnosis of thyrotoxicosis. It uses the diagnosis, therapy selection, and prognosis of Graves' disease. It's used in the assessment of thyroid function during pregnancy. It's also have a role in a preconceptual and neonatal thyroid evaluation. And it's important in special cases such as Graves' dermatopathy or Graves' ophthalmopathy. Sometimes it's used in the thyrotoxicosis on those patients who have an immune reconstitutional syndrome. Using TSH receptor antibodies can improve the time to diagnosis by nearly 46% and reduce the diagnostic cost by nearly 47%. So sometimes it may eliminate the need for additional testing. We tend to use the TSH receptor antibodies in the diagnosis of Graves' disease, in the prediction of the relapse after antithyroid drug therapy, especially if the TSH receptor antibodies persist, that suggests a higher risk of relapse. Monitor response to treatment, and it's also used in the assessment of neonatal thyrotoxicosis risk in pregnancy. The clinical significance of the measurement is to avoid the misdiagnosis and inappropriate treatment. It's a guide therapy, so to assess if there is a requirement for antithyroid drug therapy or any other adjustment therapy. It predicts the disease course. So if you have a high TSH receptor antibodies, that probably linked more into arthropathy risk. It's confirmed autoimmune etiology, and so it differentiated it from exogenous thyroid hormone use. How does the TSH receptor assay develop, or a TSH receptor antibodies assay developed? It developed many years, even before the 1970. And before 1970, there was no direct antibodies testing. We use a functional bioassay, which use patient serum added onto a culture with the thyroid cells, and they look for if any stimulation will happen. The beginning of 1970, the bioassay based on cyclic AMP production in a culture cells started to appear. Radioreceptor assay was emerged, and people start to measure the TSH receptor antibodies, but the differentiation was not possible. After 2000, the functional assay developed using a cell engineering philosophy, and the differentiation between TSH receptor antibodies, either stimulatory or blocking antibodies, were possible, and mainly used in the Graves' disease and neonatal issue. After 2010 until currently, the use of TSH receptor antibodies assay was moved to an automated assay. It's become more standardized. It's become more commercially available. And some of the cell-based bioassays still being used, but it's only in complex cases and remain in the research lab. So historically, the assay was focusing on detecting these antibodies as either stimulating or blocking antibodies separately. Modern assay only measures the total TSH receptor antibodies and does not differentiate the functional activity. The two main approaches, either you use the bioassay, which is the functional assay, or use the binding immunoassay, which is ELISA, an automated method. I'll explain that later. So the bioassay or the functional test measure the functional activity of the antibodies. So it will tell you if it is stimulating antibodies or it's a blocking antibodies. It's more sensitive, but unfortunately, it's a technical demand, labor intensive, and time consuming. It's mainly used currently in the research or specialized lab. An example of this bioassay is the cyclic AMP production assay or a cell-based assay. The binding and immunoassay detect the total TSH receptor antibodies without a functional distinction. It's a very widely used in clinical practice. It's available. It's a fully automated. It's really fast. And example of that, the use of the immunoassay in the routine lab, either by ELISA methodology, which is manual assay, or the use of the chemiluminescent or the electrochemiluminescent. The way that we measure TSH receptor in my lab is using an automated assay where we use a competitive assay. So we have a TSH binding pocket there. We add a patient serum, which will have TSH receptor antibodies. And then we also add a TSH receptor antibodies labeled antibodies. They will compete together for TSH binding pocket. And then we add another antibodies with another label that will be competing or binding only to the TSH receptor with a binding ligand, the one that we add. And then we add trigger and pre-trigger and we create light. And we convert that light into a concentration so that the way we will measure the TSH receptor antibodies. The cutoff use is different from one lab to another lab, depends on the methodology used. The one that we use in our lab is using a negative if it is less than 1.75 international unit per liters. Positive TSH receptor will be identified if the concentration is above 1.75 international unit per liter. However, knowing how the lab is measuring things, you have to put in mind that TSH receptor antibodies measurement, as well as all the other hormones and things measurement, they may suffer some interference. And so the clinician have to be alerted that if the result is not meeting the clinical pictures, then it's worth it to discuss this with the pathologist. Some of the interference can give you a positive, falsely positive result. Some of the interference can give you a false negative result. Example of false positive interference is the heterophile antibodies, which could be human anti-mouse antibodies, which can cross-react in immunoassay, and so it will mimic the receptor activity. The other false positive interference is the existence of a high concentration of rheumatoid factor. The other anti-thyroid autoantibodies, like anti-thyroid peroxidase antibodies or anti-thyroglobulin, it may cross-react with the assay and give you a false positive result. It depends on the assay methodology and the assay design. The use of high-dose biotin, especially if the assay is using biotin streptavidin-based assay, that can give you a falsely high result. On the other hand, there's other things which can give you a false negative result, such as if you have a very, very high TSH receptor antibodies concentration that give you a phenomenon called hook or bronze effect. It's really happening right now in the clinical biochemistry because people are aware of it, and so they are trying to avoid it, but it's worth to keep in your mind. And sometimes there is an assay limitation that you have to consider. Most of the assay may not be able to detect the stimulating or blocking antibodies at the same time. And sometimes it may fail to detect the neutral TSH receptor antibodies. So as a practical note, repeating testing without dilution or alternate assay format can resolve suspected interference and always interpret the data in conjunction with the clinical context. So understanding Graves' disease as one of the most frequent causes of hyperthyroidism globally, it accounts for nearly 60 to 80% of the clinical hyperthyroidism cases. It's an autoimmune disorder affecting females more than males. It presents with a sweating, palpitation, heat intolerance, weight loss, tremor, anxiety, and so on. There's a clinical utility in the diagnosis for the TSH receptor antibodies. The TSH receptor antibodies are highly specific marker for Graves' disease. It helps differentiate Graves' disease from silent thyroiditis, toxic nodules, or factitious thyrotoxicosis. The third generation TSH receptor antibodies assay probably provide nearly 97% sensitivity and nearly 99% specificity. It's really fast, more cost-effective than the use of radioactive iodine uptake or ultrasound in many clinical settings. So the measurement of TSH receptor antibodies has play a central role in the diagnosis, prognosis, and the monitoring of the Graves' disease. So it's the TSH receptor antibodies present in nearly more than 90% of the Graves' disease cases. It's responsible for the thyroid overactivity, the goiter, and the extrathyroidal manifestation. The level of TSH receptor antibodies correlate with the disease severity and recurrent risk. It's helped to differentiate Graves' disease from thyroiditis. How does that happen? If you have a Graves' disease, then you probably have TSH receptor antibodies positive. You have high uptake on the scan. You have vascular thyroid and on the ultrasound. If there's thyroiditis, the TSH receptor antibodies will be negative. There will be a low uptake, and there will be a transient hyperthyroidism. TSH receptor antibodies test reduce unnecessary imaging and treatment delay. Does TSH receptor antibodies measurement have other role on other thyroid disorder? Yes. One of them is Hashimoto's thyroiditis. The TSH receptor antibodies are a blocking type, which may contribute to this hypothyroidism. Usually, it coexists with the other autoantibodies like thyroid peroxidase antibodies and thyroglobulin antibodies. The measurement of TSH receptor antibodies is also helpful in maternal thyrotoxicosis. The maternal TSH receptor antibodies will cross the placenta, and that causes transient neonatal thyrotoxicosis. The thyroid-associated orbitopathy is another way that TSH receptor antibodies correlate with ophthalmopathy severity. So as a diagnostic algorithm, you start with the free T3, TSH, and free T4. If thyrotoxicosis is there, then you measure TSH receptor antibodies. If TSH receptor antibodies is positive, then this is Graves' disease. If TSH receptor antibodies are negative, then you need to consider thyroiditis, drug-induced, or factitious cause. So TSH receptor antibodies is a first line in ambiguous cases or in pregnancy-related cases. I think the majority of you know what is a grade score. Grade score is a clinical tool used to predict the risk of relapse in a patient with a Graves' disease after antithyroid drug therapy. The component of a grade score is the age, the level of free T4 at the diagnosis, the level of TSH receptor antibodies level at the diagnosis, and the goiter size. So the TSH receptor antibodies is a key component of the score. Elevated TSH receptor level are strongly associated with an increased risk of relapse. What about the other use as a prognostic and risk prediction for TSH receptor antibodies? If you have a high baseline TSH receptor antibodies level, that predict a poor response and higher recurrence risk. If you get TSH receptor antibodies more than 10, the lower remission probability and prolonged therapy is recommended. In terms of monitoring and follow-up, the TSH receptor, and this is in pregnancy, TSH receptor should be measured after 12 to 18 months of antithyroidal therapy. Persistence, elevation maybe suggest there is a likely relapse, and you should consider definitive therapy like radioactive ablation or surgery. Routine short interval TSH receptor antibodies monitoring not recommended. What about the role of TSH receptor antibodies in pregnancy? TSH receptor antibodies can cross the placenta, affecting fetal thyroid function. It helps to distinguish Graves' disease from gestational transient thyrotoxicosis. The gestational transient thyrotoxicosis is a self-limiting, while the Graves' disease requires treatment. So it's very important to differentiate between the two. The high TSH receptor antibodies level, 3 times the upper limit, increase the fetal hyperthyroidism risk. It can cause fetal tachycardia, growth restriction, and preterm birth. Neonatal thyrotoxicosis requires monitoring after therapy. Fetal ultrasound will help to assess thyroid function if TSH receptor antibodies are elevated. So what are the recommendations for TSH receptor antibodies testing in pregnancy? In the first trimester, you test if there is a history of Graves' disease, even if the patient are euthyroid. And again, you repeat the testing at week 18 and 22 if TSH receptor was positive at the beginning or the patient have a past radioactive iodine therapy. In the third trimester, you monitor the fetal thyroid status if TSH receptor antibodies remain elevated. TSH receptor antibodies also play a role on preconceptual planning. So it's got treatment selection for women who plan in pregnancy. Very high level may indicate the need for definitive therapy before the lady go for pregnancy. In pregnancy monitoring, all pregnant women with the current or past Graves' disease should undergo TSH receptor antibodies testing at first antenatal contact, and then if it is elevated, reassess again at the week 18 to 22, and again at the third trimester at the week 30 to 34. High maternal TSH receptor antibodies in the second trimester predict neonatal hyperthyroidism. So maternal TSH receptor antibodies more than 5, it's associated with 100% sensitivity for neonatal thyroid dysfunctioning. It's also helpful to measure TSH receptor antibodies in special population. In a neonate, if you have elevated TSH receptor antibodies in a newborn serum with a high thyroid hormone, that indicates there is a need to use antithyroid treatment. In pediatric patients, if you have a low TSH receptor antibodies and a small thyroid, that predict higher remission, and treatment decisions should be based on the receptor measurement after 3 years of therapy. Postpartum, TSH receptor antibodies help to distinguish postpartum thyroiditis from Graves' disease when presenting as a hyperthyroidism. And again, it helps in the thyroid-associated orbitopathy. If you have a baseline TSH receptor antibodies more than 8.8 international unit per liter, that predicts severe course and progression risk. So to conclude, TSH receptor antibodies are a sensitive and specific tool to differentiate the diagnosis of thyrotoxicosis. It improves the time to diagnosis by nearly 46%. It's a cost-effective. The inclusion of TSH receptor antibodies in a Graves' disease diagnostic algorithm reduced the cost of the diagnosis by nearly 47%. The available third-generation TSH receptor antibodies assay have around nearly 97% sensitivity and nearly 99% specificity for Graves' disease. And measurement of TSH receptor antibodies is crucial for the diagnosis and managing thyroid disease in pregnancy, and it does help to differentiate between Graves' disease and gestational transient thyrotoxicosis. Thank you very much. I'll be happy to handle any question.